objectives of this lecture are to discuss the indications and findings of the transabdominal approach to pelvic ultrasound, to discuss the technique, to differentiate between an intrauterine pregnancy or an IUP from no definitive IUP, to estimate gestational dating, and finally, to discuss the limitations and pitfalls of the transabdominal approach to pelvic ultrasound. There are many indications and potential findings for the transabdominal approach to pelvic ultrasound. Indications can include patients who present to the ED with complaints of vaginal bleeding, abdominal pain, differentiating between an intrauterine versus ectopic pregnancy, or threatened abortion. Potential findings can include an intrauterine pregnancy or a threatened abortion, no definitive IUP, in which case the differential diagnosis would include an empty uterus or indeterminate pregnancy, molar pregnancy, or ectopic pregnancy. An additional potential finding on transabdominal ultrasound would be retained products of conception. In order to illustrate our indications and potential findings of the transabdominal approach to pelvic ultrasound, we will begin with a case. The chief complaint is nausea. We have a 17-year-old female with 2 weeks of nausea, who is otherwise asymptomatic. She can't quite remember her LMP, but thinks it might be 2 months prior to the current ED visit. On physical exam, her vital signs are within normal limits, and she has an otherwise unremarkable exam. Her urine pregnancy is positive. In order to confirm an IUP in our patient, we will need to conduct a pelvic ultrasound. The approach that we decide to take will largely be determined by the approximate gestational age of the pregnancy, with the transvaginal pelvic ultrasound being able to detect an IUP as early as 5 weeks gestation, and a transabdominal ultrasound being able to detect an IUP as early as 6 to 7 weeks gestation. For the purposes of this lecture, we'll be focusing on the transabdominal approach. Please refer to the other SAEM Ultrasound Lecture series on the transvaginal approach to pelvic ultrasound for further detail on that technique. Before we get started, we need to pick the appropriate probe for our study. Our options include the high-frequency linear probe, which has limited imaging depth, the low-frequency phased array probe, which has increased imaging depth, and the endocavitary probe. For a transabdominal pelvic ultrasound, the best probe would be the phased array probe, or the curvilinear probe, which will provide the appropriate resolution and imaging depth for visualization of the pelvic structures. Prior to starting your study, it is important to make sure the patient has a full bladder, which will be used as a sonographic window into the pelvic structures. As with any ultrasound technique, it is important to view your structure of interest in 2 planes. In this anatomical diagram of a pelvis in the sagittal plane, the bladder, vaginal stripe, uterus, and pouch of Douglas have been highlighted. When performing the ultrasound in the sagittal plane, the probe marker should be pointing cephalad. In a corresponding ultrasound image, the bladder is identified as a well-circumscribed, fluid-filled anechoic structure. The cervix appears just posterior to the bladder angle, with the uterine body to the left of the angle and the vaginal stripe to the right. Just cephalad to the bladder, the uterus appears as a hypoechoic structure with thick walls and a well-defined border. The posterior cul-de-sac, or the pouch of Douglas, is posterior to the uterus and may be the site of free fluid collection. In this anatomical diagram of a pelvis in the transverse view, the bladder, uterus, and pouch of Douglas have been highlighted again. When performing the ultrasound in the transverse plane, probe placement is just like placement for the pelvic view on fast exam, with the probe marker pointing to the patient's right by convention. In a corresponding ultrasound image, the bladder, uterus, and pouch of Douglas have been highlighted. Adnexa may be found lateral to the uterus on either side, but are usually poorly visualized in the transabdominal view. Once you have identified the pelvic structures, the next step in confirming an IUP is identifying what, if any, structures are seen in the uterus which are determined by the gestational age of the pregnancy. The first sonographic sign of an IUP that can be seen on transabdominal pelvic ultrasound is the gestational sac at 6 weeks, followed by the yolk sac, which oftentimes looks like a Cheerio. At 7 weeks gestation, a fetal pole can be identified with a fetal heart rate. The fetal heart rate can be measured on M mode. In this image, the fetal heart rate is measured to be 150 beats per minute. Spectral Doppler should not be used, as this use carries a theoretical risk of exposing the fetus to higher energy levels. At 8 weeks onwards, fetal structures have begun to develop and can be visualized on transabdominal ultrasound. This is a chart outlining the earliest gestational age at which structures of fetal development are seen on the transvaginal and transabdominal approach, with structures identified on transabdominal approach 1 to 2 weeks after they can be identified on the higher resolution transvaginal approach. Some of the literature suggests that the earliest corresponding serum beta HCG level at which a gestational sac can be visualized is at approximately 5,000 milliunits per milliliter. The serum level, or discriminatory zone, is controversial and will be addressed at a later slide. The sonographic findings that are considered to confirm an IUP are visualizing a gestational sac with a yolk sac, or identifying a fetal pole with a fetal heart rate. Now, back to our case of the pregnant female who presents with nausea. We conduct a transabdominal ultrasound and visualize a gestational sac and a yolk sac. Her beta HCG is 10,000. Based on these findings, we can state that this patient has a confirmed IUP. When an IUP is identified, the endomyometrial mantle should be measured as the full thickness of both the endometrium and myometrium combined. An endomyometrial mantle thickness of greater than or equal to 8 millimeters is considered normal and minimizes the risk of an interstitial or corneal ectopic pregnancy. An EMM of less than 8 millimeters warrants close follow-up with OB/GYN. But how easy is it to learn pelvic ultrasound? Jang et al. Sought to assess the learning curve of emergency physicians using bedside ultrasound for symptomatic first trimester pregnancy. In this study, they looked at 630 patients with first trimester bleeding or pain who had a transabdominal and transvaginal bedside ultrasound. In this study, they defined an IUP as a gestational sac with a yolk sac or an intrauterine fetal pole. Enrolling physicians grouped their scans by blocks of 10, with Group 1 having completed 1 to 10 scans, Group 2 having completed 11 to 20 scans, and so on. And what they found was that the sensitivity and specificity for identifying an IUP increased from 80% and 86% respectively for the first 10 exams to 100% sensitivity and specificity after 40 examinations were performed. So the take-home message is that the skill of emergency bedside ultrasound increases with experience. So with increasing experience, physicians are able to reliably perform studies. But does this actually help with ED flow? Blavis et al. Conducted a study in which they evaluated whether emergency physicians could save time when locating a live IUP with bedside ultrasound. In this retrospective chart review of 1,400 women with first trimester bleeding and pain, they conducted 277 bedside ultrasounds. 1,100 women went to the Department of Radiology for their ultrasounds. And what they found was that in patients in whom an IUP was determined by bedside ultrasound, the length of stay was actually 21 to 28% shorter than if the ultrasound had been performed by the Department of Radiology, with the average length of stay being 48 minutes shorter during the daytime and 1 hour and 17 minutes shorter during the nighttime. McRae et al. Conducted a systematic review of the diagnostic accuracy and clinical utility of ED ultrasound in identifying an IUP in women who presented with pelvic pain and/or bleeding during the first trimester. They looked at prospective studies in which either transabdominal or transvaginal ultrasound was performed, and the gold standard was considered sonographic reports from the Department of Radiology, or GYN. Their results showed that emergency ultrasound was able to identify a definitive IUP with an average sensitivity of 90% and a specificity of 98%, demonstrating that ED physicians are able to identify an IUP on bedside ultrasound. Now that we've discussed the technique for transabdominal pelvic ultrasound and some of the literature supporting the use of bedside ultrasound in first trimester pelvic pain and bleeding, let's move on to our next case. Chief complaint is abdominal pain, and we have a 27-year-old female with suprapubic pain for 1 day with associated cramping and vaginal spotting. On exam, her heart rate is 110 beats per minute and her blood pressure is 110/70. On exam, she is noted to have suprapubic pain with blood in the introitus. Her urine pregnancy is positive. When we do the pelvic ultrasound, these are the images that we obtain. Criteria for confirming an IUP relies upon identification of a gestational sac with a yolk sac, neither of which can be seen in these images. The patient's beta HCG is 5,000. Based on these findings, we can state that this patient does not have a definitive IUP. Our differential diagnosis at this point includes an early IUP, a threatened abortion, ectopic pregnancy, or molar pregnancy. Ectopic pregnancies occur in approximately 2% of all pregnancies and is the leading cause of maternal death during the first trimester of pregnancy. When evaluating a pregnant patient who presents with vaginal bleeding or pain, it's important to interrogate the whole pelvis, as ectopic pregnancies can be found in various places throughout the female pelvis, such as the cervix, intramurally, interstitially, or anywhere along the tube. The anexa, or intra-abdominally. However, the vast majority of ectopics occur in the ampulla. If an empty uterus is visualized, this should prompt a transvaginal ultrasound to determine if the higher frequency endocavitary probe can detect an early IUP that is not detected on transabdominal. If on transvaginal ultrasound there's still an empty uterus, the patient should be referred to the Department of Radiology for a confirmatory study and OB/GYN should be consulted. In hemodynamically unstable patients who are known to be pregnant, Morrison's pouch should be the first image that is interrogated. Pregnant patients with free fluid in Morrison's pouch are considered to have a ruptured ectopic until proven otherwise. A potential pitfall is mistaking a pseudogestational sac for a gestational sac or an early IUP. A pseudogestational sac is caused by the breakdown of stimulated endometrial lining from an ectopic pregnancy and can be mistaken for a viable potential IUP. The pseudogestational sac is seen in 10 to 20% of ectopic pregnancies and can be differentiated by its central location in the uterus, oval shape, thin echogenic rim, and lack of a chorionic ring. If there is any doubt regarding what is visualized on bedside ultrasound, the patient should be referred to their Department of Radiology for a confirmatory study an OBGYN should be consulted. As mentioned in a previous slide, certain sonographic findings are expected when there's a known gestational sac or a specific beta-HCG level, known as the discriminatory zone. However, the exact beta-HCG level that's considered to be the discriminatory zone is controversial. In a recent study by Duboulay and Benson, they identified 200 patients who had no definitive IUP that was identified on initial ultrasound despite a positive serum beta-HCG, who were subsequently found to have a live IUP on repeat ultrasound. And what they found when they reviewed the beta-HCG levels of all 200 patients was that there was no relationship between the initial beta-HCG level and the first trimester outcome of final pregnancy outcome, even when stratifying the groups based on initial beta-HCG level of less than or greater than 1,000. In an earlier study done by Rousseau et al., in which they sought to determine what factors may predispose patients to the rupture of a tubal ectopic pregnancy, they evaluated 99 cases of ectopic pregnancy and found that tubal rupture was encountered more often in women with no history of ectopic pregnancy, less often in lower age ectopic pregnancies, and that the beta-HCG level does not predict tubal rupture. The take-home point from this study is that tubal rupture is more often observed in women with no history of ectopic pregnancy and in women with full-term pregnancy. Such observations suggest that ectopic pregnancy is less suspect in these cases. In a different study by Tile et al., they studied the outcome of patients with an indeterminate bedside ultrasound performed in the ED to rule out ectopic pregnancy. In this study, they identified 1,400 women who had first trimester bleeding or pain. An IUP was defined again as a gestational sac with a yolk sac or an intrauterine fetal pole. All patients who were found to have an indeterminate ultrasound were followed up. On these initial ultrasounds, 20% of women had an indeterminate ultrasound. On these initial ultrasounds, 2% of patients were also found to have an ectopic. On follow-up of those 20% of indeterminate ultrasounds, 15% had an ultimate diagnosis of an ectopic pregnancy. All ectopic patients were followed for their mode of treatment, either medical methotrexate or surgery. In ectopic patients diagnosed on the initial ED visit, 83% were treated surgically compared to only 36% of patients who had an initial indeterminate ultrasound. In this study, they found that earlier identification of an indeterminate ultrasound with the eventual diagnosis of an ectopic pregnancy had a higher rate of medical methotrexate treatment and a reduced rate of invasive surgical treatment, compared with ectopic pregnancies that were diagnosed on initial ED visit. A recent meta-analysis by Stein et al. Evaluated pregnant women with first trimester bleeding and pain who had either transabdominal or transvaginal ultrasound. And they were able to demonstrate that emergency physicians were able to screen for an ectopic pregnancy with a bedside emergency ultrasound sensitivity of 99.3%, negative predictive value of 99.96%, and a negative likelihood ratio of 0.08 across a wide variety of practice environments. Take-home message from this study should be that visualization of an IUP by an emergency physician is able to rule out ectopic pregnancy. In this study by Moore et al., they evaluated women who had first trimester bleeding and pain with a bedside transabdominal pelvic ultrasound in which they also interrogated the hepatorenal space. They followed up all these patients with a radiology or operative report or for their final pregnancy outcome. And what they found was in patients with a suspected ectopic pregnancy on pelvic ultrasound, free intraperitoneal fluid found in Morrison's pouch could be rapidly identified by emergency ultrasound and was predictive of the need for operative management with a positive likelihood ratio of 112, compared to a positive likelihood ratio of only 2.7 when free fluid is found anywhere in the pelvis. This study of evaluating the right upper quadrant as well as the pelvic structure took an average of 4 minutes and 27 seconds to complete in the emergency room. The take-home message from the study suggests that free fluid in Morrison's pouch is able to rapidly identify and predict the need for operative intervention. While an ectopic pregnancy is highest on our differential when evaluating a pregnant patient who presents to the ED with bleeding or pain, there are other diagnoses on our differential diagnosis. To demonstrate an alternate diagnosis, what would be the diagnosis if we performed a transabdominal ultrasound on our patient and saw these images? There's no gestational sac and no yolk sac. This patient's beta HCG came back at 200,000. Based on these findings, we can state that this patient does not have a definitive IUP and has findings that are most concerning for a molar pregnancy. Let's move on to our final case. Chief complaint of abdominal pain. We have a 26-year-old female who states that she thinks she might be 7 weeks gestational age with an intermittent abdominal pain. However, she does not quite remember her last menstrual period or her estimated delivery date. On exam, her vital signs are within normal limits, but she has a gravid abdomen that is inconsistent with a 7-week gestation. On our bedside transabdominal ultrasound, we see a fetal pole with a fetal heart rate, so we can confirm that there is an IUP. However, our patient states that she is about 7 weeks pregnant, which does not seem to correlate with our findings on ultrasound. So how do we determine the gestational age of this IUP? Once we have identified a fetal pole, the first sonographic measurement that can be done on a fetal pole to estimate gestational age in the first trimester is the crown rump length, which is defined as the longest length of the fetal pole from the crown or cephalic pole to the rump, the caudad pole, ignoring curvature. This measurement should not include the yolk sac or limbs. In this image, the gestational age is estimated to be approximately 12 weeks. In the second trimester, the best estimate of gestational age can be made by measuring the biparietal diameter at the level of the third ventricle. In this sonographic image, the falx cerebri, thalamus, and third ventricle are labeled. When measuring the biparietal diameter, it is important to measure the outer edge of the near calvaria wall to the inner edge of the far wall. In this age, the gestational age is estimated to be approximately 22 weeks. It is important to note that after 26 weeks of gestation, the BPD may be inaccurate, secondary to growth and/or nutritional abnormalities. In the third trimester, the best estimate of gestational age can be made by measuring the femur length, which is done by measuring the ossified portion of the diaphysis and metaphysis, including the femoral head and distal femoral condyle. Be careful not to measure the cartilaginous portions and also to not measure the humors by identifying related femoral landmarks such as the bladder and the iliac bones. In this image, the gestational age is estimated to be approximately 19 weeks. Measurements done during the first trimester of pregnancy are considered to be the most accurate in estimating gestational age to within 1 to 2 weeks compared to measurements taken in later trimesters, which can be accurate to within 2 to 3 weeks depending on the trimester. Shaw et al. Studied the accuracy of emergency physicians in using ultrasound to determine the gestational age. This was a prospective observational study of 38 women who were in their second or third trimester of pregnancy, and the emergency physicians obtained measurements of the biparietal diameter, femur length, and fundal height, and compared their measurements to those obtained by the Department of Radiology and GYN. In Table A and B, the x-axis is the gestational age as determined by bedside ultrasound, and the y-axis is the true gestational age as determined by the Department of Radiology or GYN. As you can see, there is a strong correlation indicating with measurements of the biparietal diameter in Table A and the femur length in Table B, with the correlation coefficient of 0.95 for the BPD and 0.96 for femur length. The overall accuracy for viability cutoff was 96% using ultrasound and 80% using fundal height. Ultrasound measurements were within 2 weeks of true age, while the fundal height was within 40 days of true age. The test characteristics for BPD and femur length were also higher in both sensitivity and specificity when compared with fundal height. This study suggests that bedside ultrasound is able to determine gestational age and may be more accurate compared to fundal height measurements, which can be unreliable, particularly in patients who are obese or who present with uterine rupture or trauma. Now that we have discussed the indications, findings, and technique for the transabdominal approach to pelvic ultrasound, as well as reviewed the supporting literature, it is important to note some limitations of this approach. Limitations include the ability to rule out ectopic pregnancy when the pelvic ultrasound shows indeterminate findings that do not confirm an IUP. In such scenarios, it is important to correlate clinically when determining the next steps in management. In addition, patients who have undergone assisted reproductive technology and are at risk for heterotopic pregnancies require a thorough ultrasound examination by the Department of Radiology to rule out the presence of an ectopic pregnancy. Lastly, focused emergency ultrasound is not sufficient for identifying or ruling out fetal abnormalities, or for evaluating pelvic anatomy after vaginal rectal surgery. Pitfalls to successful interpretation of pelvic ultrasound images include attributing an empty uterus to a very early IUP, an ectopic pregnancy, or a completed spontaneous abortion. Failure to identify a heterotopic pregnancy, mistaking a pseudogestational sac for a gestational sac, and misidentifying an adnexal mass for an ectopic pregnancy. In summary, key points to remember when using the transabdominal approach to pelvic ultrasound are to remember one of its primary indications, which are to confirm an IUP in pregnant patients with bleeding or pain, with a confirmed IUP being defined as a gestational sac with a yolk sac or a fetal pole with a fetal heart rate. In patients with no confirmed IUP on ultrasound, they should be managed as a rule-out ectopic until proven otherwise by confirmatory study by the Department of Radiology or GYN. In hemodynamically unstable pregnant patients, Morrison's pouch should be the first image that is obtained to evaluate for a ruptured ectopic. GYN should always be consulted if there is no definitive IUP and in all patients who are at risk for a heterotopic pregnancy. These are the references for this lecture. That concludes our lecture on transabdominal pelvic ultrasound.